Intermediate and high-risk prostate cancer is associated with nodal metastasis in more than 25% of men. Accurate surgical localization and removal of the sentinel nodes may help identify the value of nodal resection in prostate cancer patients and provide better staging. Here we present our manuscript entitled Intraoperative Laparoscopic Fluorescence Guidance to the Sentinel Lymph Node in Prostate Cancer Patients, wherein we present the first clinical proof of an integrated functional imaging approach using a multimodal tracer. The concept that we introduce is the use of a single multimodal imaging agent that is both radioactive and fluorescent for surgical guidance towards the sentinel lymph nodes. This procedure is explained in the following scheme. The imaging agent is injected into the prostate guided by ultrasound. After lymphatic migration, preoperative gamma imaging facilitated by the radioactive component of the multimodal imaging agent allows for identification of the sentinel lymph nodes and provides useful anatomical information which can be used to help plan the surgical procedure. During surgery, the urologist uses the fluorescent component of the multimodal imaging agent to optically identify the sentinel lymph nodes during robot-assisted prostatectomy. After validating the concept in preclinical studies in mice, this is the first study in humans describing such an integrated imaging approach for intraoperative surgical guidance. In this study, we included 11 patients with prostate cancer of intermediate prognosis who were scheduled for robot-assisted prostatectomy and a lymph node dissection between June 2010 and January 2011. All patients gave written informed consent to include fluorescent intraoperative imaging into their otherwise standard sentinel lymph node procedure with radioactive technetium-labeled nanocoal alone. The multimodal imaging agent consists of technetium-labeled nanocoal combined with the near-infrared dye indocyanine green. Preparation of the hybrid tracer is relatively simple as the near-infrared dye indocyanine green and the albumin-based radiocolloid nanocoal form a complex via self-assembly. We have previously shown this yields a hybrid radiocolloid that is both radioactive and fluorescent. The principal advantage of this hybrid tracer is that next to its optical properties, it retains the well-established functional properties of technetium-labeled nanocoal alone, and thus accumulates in the sentinel lymph nodes, which indocyanine green alone does not. As both components are approved for clinical use, this hybrid compound could be easily translated to the clinic. The GMP production of the hybrid tracer is briefly shown. A portion of ICG solution is added to a standard technetium-labeled nanocoal solution. The multimodal complex is then formed in situ. After a short incubation time, the required amount of this solution can be withdrawn from the vial using a syringe. Approximately 3 hours prior to surgery, the multimodal imaging agent is injected transrectally into both lobes of the prostate, guided by ultrasound. Adequate tracer concentration in the prostate is then confirmed with a portable gamma camera, which is facilitated by the tracer's radioactive component. 15 minutes and 2 hours post-injection, static planar gamma camera images were acquired. As such, time-dependent migration of the imaging agent through the lymphatic system is visualized, enabling identification of the first tumor-draining sentinel lymph nodes. Immediately after lymphoscintigraphy at 2 hours post-injection, SPECT-CT was performed to match the radioactive signal provided by tracer accumulation in the sentinel lymph nodes with the anatomy of the patient as visualized by CT. SPECT-CT thereby provides useful anatomical information regarding the location of the sentinel lymph nodes and allows for the identification of sentinel lymph nodes that lie beyond the standard dissection margins. The next challenge was to integrate this information into the surgical procedure. The 3D SPECT-CT image is depicted in the OR to help the urologist to navigate towards the locations of the sentinel lymph nodes during robot-assisted prostatectomy. Here we give a brief overview of the technical setup used in the OR, depicting the surgical robot system, the console, and the view through the surgical goggles. Based on the SPECT-CT image, the exposure of the sentinel lymph nodes is initiated. For intraoperative identification of the sentinel lymph nodes, both a conventional acoustic gamma probe and a near-infrared optimized fluorescence laparoscope were used. The laparoscopic gamma probe aids the navigation process as it provides acoustic guidance towards the rough locations of the sentinel lymph nodes. Finally, fluorescence laparoscopy is used to provide a high-resolution and real-time visualization of the sentinel lymph nodes during their exposure and excision. We found this to be especially valuable in high background areas where acoustic gamma tracing is difficult. As shown in section 3 of the scheme, the fluorescence signal can be divided in both blue and green. We found that the contrast generated in green gives superior optical guidance. In addition to guiding the urologist to the sentinel lymph nodes, both the radioactive and fluorescent emissions can also be used as control to make sure the sentinel lymph nodes identified on SPECT-CT are completely excised. After this confirmation, the tissue specimen containing the sentinel lymph node can be harvested. In the 11 patients included in this pilot study, a total of 27 sentinel lymph nodes were excised, of which 3 contained tumor metastases. A total of 112 lymph nodes were removed. As this second scheme illustrates, both the radioactive and fluorescent emissions can also be detected ex vivo. Ex vivo fluorescence imaging can visualize the exact location of the sentinel lymph node in the excised tissue specimen. This can help guide the pathologist in their analysis of the excised tissue. More importantly, quantitative ex vivo monitoring helps prove there is a complete overlap in radioactive and fluorescent signal intensities. This in turn is an indication that the hybrid tracer is stable throughout the entire imaging process. Therefore, ex vivo correlation of radioactive and fluorescent signal intensities was determined in all excised lymph nodes using a dedicated gamma camera and fluorescence camera. Examination of the 112 excised lymph nodes revealed high correlation in signal intensities with an average R² of 0.91. Although we have shown ex vivo that all radioactive lymph nodes were also fluorescent and vice versa, it was not possible to intraoperatively locate all sentinel lymph nodes detected by SPECT-CT with the gamma probe or the fluorescence laparoscope. We found that in some cases the sentinel lymph nodes were embedded in tissue, preventing accurate optical detection due to attenuation of the fluorescent signal. However, in some cases the high background signal coming from the prostatic fossa prevented accurate gamma tracing, making optical guidance vastly superior in these areas. In conclusion, we have shown that it is possible to generate an integrated surgical guidance procedure using a multimodal imaging agent. Herein, the radioactive component guides the surgeon towards the sentinel lymph nodes. This helps to overcome the shortcoming of fluorescence imaging, namely the limited tissue penetration. In turn, we have also demonstrated that the addition of a fluorescence signal provides real-time fluorescence-based surgical guidance and may help overcome limitations of acoustic intraoperative gamma tracing. In these cases, both components are truly complementary to each other. Therefore, we find the hybrid approach to be superior over the conventional technetium nanocall approach. We are currently expanding the use of this concept to other malignancies.